Good morning. I'm going to cycle through these slides, which are very quick because I have no disclosures. Today we'll talk about the role of the life story perspective in understanding patients and the way we formulate individualized treatment plans in a community psychiatry setting. And I'll talk about the 5 pillars of resilience, how to promote resilience-focused interventions to reconstruct narratives of growth and healing. The rest of our CMEs. I'm inspired by the resilience of patients in community psychiatry, and perhaps resilience has been a bit more on my mind as I've been recovering from knee surgery and finding that it takes some effort to adapt and change when life throws us a curveball. Might not be as serious as some others, but makes you pause or forces you to pause for a while, which is why I had a lot of time to read as I was recuperating on the couch after reconstructive surgery and came across Dr. Jameson's most recent book, which was so inspiring to me and really led to a lot of the points that I wanted to make during the talk today. She was kind enough to give me permission to use some excerpts from her book today. This is one from Beyond All Reason that says, to sit quietly in a consulting room and talk to someone would not appear to the general public as a heroic or dramatic thing to do. But in medicine, there are many different ways of saving lives, and this is one of them. I'm going to talk today a little bit about the brief life story of psychiatry and community psychiatry at Hopkins. I'll talk about the life story perspective as part of the 4 perspectives, bring around the 5 pillars of resilience and the way we design interventions to promote growth and healing in community psychiatry. The Phipps Psychiatric Clinic opened its doors in April of 1913. And it was built upon a $1.5 million donation from philanthropist Henry Phipps, who was inspired in part by Clifford Beer's autobiography, A Mind That Found Itself, which was published in 1908, the year that Dean William Welch spoke with Henry Phipps about the need at Hopkins and in Baltimore to have our own Department of Psychiatry. And then Dean Welch recruited Adolph Meyer from Columbia to be our first psychiatrist-in-chief. So Adolph Meyer, as our first leader for 30 years, really built the foundation of the way we care for patients based on a model of a comprehensive, systematic history and physical exam, which is still the format that we use today for our written and our oral presentations. I learned about John Whitehorn, who succeeded him as the second psychiatrist-in-chief, who had an interest in the process of psychotherapy. And he had noticed that the patients with whom he developed a relationship tended to improve more than others. That led to his work with Barbara Betts on the effectiveness of psychotherapy with the schizophrenia patient. Not something we always think about, but I'm glad to see that that was a part of teaching as far back as the 1960s and 70s. Through that work, he showed that psychiatrists who took an active role in psychotherapy with their patients showed 3 times more clinical improvement in their patients with schizophrenia. And that's definitely not nothing. This was around the same era as Jerome Frank, who is a bedrock of all of our bookshelves. Right? Persuasion and healing, something that I look to for guidance over and over, can never read it enough. His contributions to understanding psychotherapy and the importance of the therapeutic alliance still hold true today. And 35 years after Adolph Meyer, Dr. Meuchel became our psychiatrist-in-chief. And it was during his time here that he developed and published the 4 perspectives with Dr. Slavny, right? Our framework for interpreting the information from a comprehensive history and physical through 4 perspectives for a personalized understanding of our patients and their complicated conditions. Dr. Meuchel is also responsible for the Meuchel program for human flourishing, and the director, Meg Chisholm's book from 2021 is called Living Your Best Life with Mental Illness, From Survive to Thrive. It's really the first practical guide for patients and their families, explaining the way we practice psychiatry in the 4 perspectives. It describes health as a state of complete physical, mental, and social well-being. That is not the absence of disease or infirmity. Also under the leadership of Dr. Meuchel, Dr. Bill Brakey and Dr. Anil Prim developed CoSTAR as far back as 1985. So CoSTAR, for those of you who aren't familiar with it, stands for Community Support, Treatment, and Rehabilitation. Dr. Brakey published his initial findings in the British Journal of Psychiatry in 1991, showing that long contact with patients improved their social functioning and markedly improved the quality and quantity of social networks. CoSTAR, like our present-day ACT program, provided a combination of mobile treatment, case management for patients with severe mental illness. It was described at the time as an assertive, home-based psychiatric treatment and really focused on training those patients in community living. It was developed at a time when there was a need for potentially indefinite outpatient care for patients that were leaving long-term institutionalization. Many great hearts and minds worked together to build our outpatient clinics and shape the care that we provide in community psychiatry. The initial CoSTAR team included our very own Barbara Schweitzer. The initial CoSTAR team was 6 nurses, 3 social workers, 1 counselor, and 2 part-time psychiatrists. So I had no idea that Dr. Janofsky was part of that early CoSTAR team. I sent him a text message not realizing that he was out of the country, traveling the world, enjoying his retirement, because I had not been in the hospital when he retired to hear that story. He responded right away and told me stories by text about the old days in CoSTAR and community psychiatry. So not only Dr. Janofsky, but Dr. J-Ram, Mickey Kaminsky, the late Bruno Lima as well. And then so many notable nurses and therapists as well. I can't name them all. Barbara Schweitzer, of course, Miriam Nichols. And I would be remiss if I didn't mention Karen Ball, who's been working in CoSTAR and mobile treatment and now ACT for 40 years. When I asked her how she's done this for 40 years with our patients with the most severe mental illness, she laughed, as she would, and said, it's basically grace and chocolate. So now ACT is under the leadership of Dr. Spivak and Shari Green, and I think it's remarkable that the expectations for those patients have changed. Where Karen told me originally the saying was, once a CoSTAR patient, always a CoSTAR patient. But that's not the way it is today. We actually see our patients improve with a recovery model, and they graduate from ACT and might advance to our outpatient mental health clinic. Sometimes there's some flow back and forth, but as needed, we adjust. So it's nice to see that idea of our patients not being able to improve anymore has softened, and we expect them to continue to improve. Our roots in the community psychiatry program are obviously grounded in the Hopkins approach to psychiatry, and we've been led for the last couple of decades by Dr. Cullen. Our family tree, so to speak, has a few branches. The ACT program is still in the original building on Caroline Street, where it was CoSTAR first started in an empty room in 1985. CoSTAR is now led by Dr. Spivak and Shari Green. They still have, when they're fully staffed, about 10 staff and a ratio of patients to staff of 10 to 1. Our outpatient mental health clinic is located in Meyer 144, and under the direction of Dr. Cullen, continues to function with a team approach where every patient is assigned both a therapist and a psychiatrist. We work together, we meet with the patients together, we support each other, and it's that team approach that often keeps our staff, our providers, our clinicians there for years and decades. Our intensive outpatient program is a small in-person group-based program, 3 half-days a week, and we have a small Hispanic clinic as well. We're blessed to have a bilingual therapist and a small grant from BHSB to work primarily with undocumented patients in the area. So whether we're treating a patient at ACT or in our Hispanic clinic, we're all guided by those teachings of Meuchel and Meuchel, with an understanding of psychotherapeutic persuasion and healing from the work of Jerome Frank. And we all strive to be healers of the mind, as Kay Jamison describes, for our patients with severe mental illness. I couldn't say any of this as eloquently as Kay, which is why I asked if I could include some of her quotes today. To be demoralized is to feel overwhelmed and chartless, disheartened by life circumstances, including depression, trauma, grief, physical illness. The mastery of life's direction is the aim of psychotherapy, Paul McHugh and Philip Slavny write in The Perspectives of Psychiatry, a book that shaped the clinical practice and intellectual lives of several generations of psychiatrists. It's facilitated by learning how events of the past and aspects of one's own character have conspired to produce prior frustrations and recurrent demoralization. It's a very brief overview of the perspectives. It is our framework for an individualized, multi-layered diagnostic formulation of complex problems, recognizing the unique aspects of each individual in terms of these 4 lenses: the disease perspective, dimensional perspective, the behavior perspective, and the life story perspective. So I've gleaned from some of the teachings of Dean McKinnon for our trainees over the last few years. We teach our trainees to remember the 4 perspectives with the acronym HIDE, the disease perspective for what a patient has, an abnormal structure or function, the dimensional perspective for what a patient is, their individual cognitive and temperamental features that give them unique strengths and personality, vulnerabilities. The behavior perspective, or what a patient does, which is goal-directed actions that involve choice, physiological drive, and conditioned learning. And finally, the life story perspective, or what a patient encounters, the meaningful connections that they make between past events and present circumstances that come together to produce a unique narrative. The life story perspective, like growth rings on a tree, is unique to each individual. The tree's growth rings might tell us whether some seasons were particularly rainy or particularly dry. You might even see a scar from a forest fire and regrowth afterwards. And unique to each of our patients is the story that they come with, the connections that they make between past events and where they are today. And that life story helps us to understand and interpret their disease, their dimensions, and their behavior. Kay Jamison describes constructing life stories as being critical to psychotherapeutic work. And in order to construct those life stories, we often have to ask questions. We're blessed in this field to have lots of time and be encouraged to spend lots of time with our patients, and in community psychiatry to develop these relationships and have that life story perspective grow over time. It's dynamic. But we have to ask questions like, what brings you to see me and why now? What matters to you and what does this mean to you? Constructing life stories is more than learning about a particular setting, a sequence of events, and an outcome, right? Like my Kids love Legos, and these are some Lego representations of family trees where you can see that if you were to rearrange the blocks, it would change the story. The goal of psychotherapy based on the life story perspective is to re-script the narrative and to help our patients find meaning in what they have encountered in their life. We use that as a way to remoralize our patients and help them to find a hopeful way to move forward. Kay Jamison writes about psychotherapy as a quest to find out who the patient is and how they came to be that way, a journey to find out what they enjoy, what their strengths are in life, to find fresh ways to grapple with past, present, and future, to discover innovative ways to ameliorate pain and amass joy. And the therapist's understanding of this patient needs to remain open and fluid. It must be free to organize and grow, brought into light and into words. Depression, grief, anxiety, madness, and trauma can be better grasped, better able to put use to change suffering into something more endurable or serviceable. In community psychiatry, our patients present to us with very difficult histories of trauma, discrimination, demoralization, loss, catastrophic physical illnesses, and often with questions like, why me? So Viktor Frankl is another one of the books that has a prominent place on my bedside table. This is his autobiography about surviving the Holocaust and how to turn personal tragedy into triumph. So Viktor Frankl writes, if life is to have meaning, then suffering must have meaning. And yet, the cost of suffering can be seen in the signs and symptoms of acute and chronic stress. Stress is one of the things that tends to be associated with flares of her lupus. We see patients that present with many of the signs and symptoms of depression. If their self-attitude is still intact, they might still have changes in sleep, interest in things, energy, concentration, appetite. They might experience physical symptoms like irritable bowel symptoms, chest pain, back pain, headaches, inflammatory diseases, right? Flares of lupus, hypertension, diabetes, and of course this also affects their propensity for addiction and for recurrences of depression and anxiety. We're susceptible to that as well. So it's important for us as providers to remember ourselves that stress affects us, and we all experienced that during the pandemic. This is from the 2020 National Physician Burnout and Suicide Report, where at the time nearly half of all physicians surveyed reported experiencing burnout. It was interesting that psychiatrists were much lower on the list. It was 35% of the psychiatrists surveyed that endorsed burnout at the time. Many of the physicians pointed to things like administrative burden as one of the main drivers for burnout, but compassion fatigue was also there as well. We're fortunate in community psychiatry, again, to take care of our patients with this team model where we can lean on each other and learn from each other and sometimes vent to each other, but also support each other. I also found it interesting to see the types of coping skills that physicians endorsed using to cope with burnout. Number one on the list was isolating themselves. Now, with this being in the context of 2020, that could have been physicians that were working on COVID units and were isolating themselves to protect their families from the risk of infection before we had vaccines and medications. And yet, I think it's something that we all tend to do at times. Also high on the list were things like exercising and talking to friends and family. Not insignificant on the list were almost a quarter of physicians that endorsed drinking alcohol to cope with stressors, 20% endorsed binge eating, and 1 to 3% endorsed either smoking or using nicotine, using prescription drugs, or using cannabis. So, why is it that some people bounce back or even thrive under stress? This is what we call resilience and what we try to encourage in our patients in community psychiatry and in ourselves. It's the ability to adjust to or recover from adversity. I have a patient who likes to remind me that no medication is going to change my life circumstances, doc. Tells me that all the time. And yet, there is a role for the medication that we prescribe and also the contributions of psychotherapy to continue to work on the ways that we cope with stress. Very few things are under our control in our lives, so let's try and find the few things that are and focus on what we can do to affect change in the things that we do have control over. The therapeutic approach from a life story perspective, again, is to re-script, remoralize, find a more hopeful way forward. And this is a picture of the resurgence of a forest after a forest fire. So, again, the good news is that we can build resilience. And one of the programs that has inspired me is the Bounce Back Project that was born in 2015 in a small county in Minnesota after they lost 2 local physicians very close in succession to each other. It's similar to the Meuchel program for human flourishing, right? That idea of going from surviving to thriving, and the 5 pillars of resilience that help us to retrain ourselves and to focus on positivity and improving feelings of well-being include self-care, self-awareness, purpose, mindfulness, and positive relationships. So in order to cultivate resilience in our community psychiatry program, we talk with all of our patients about self-care. In order to prevent burnout and to counteract stress, it's important to take breaks in order to refocus. And the exact self-care regimen that works for each patient is unique to each patient. So we talk with all of our patients about sleep hygiene, healthy nutrition, physical activity. We might talk with them about medication adherence and order prepackaged medications for them, or have them bring in their pill box for us to help them organize their medications. Or we may transition to a long-acting injectable when we see that taking medications by mouth is not one of their strengths. In terms of self-awareness, we're talking about the understanding of individual strengths, vulnerabilities, core beliefs, motivations, triggers. And likewise with mindfulness, that idea of staying active and open, paying attention to the present moment, observing thoughts and feelings without judgment, not labeling our thoughts as good or bad. We draw from the skills that we've learned in CBT and DBT, and some of our therapists incorporate acceptance and commitment therapy as well to develop these skills in our patients. In terms of positive relationships, it makes me think back to CoStar when patients were coming out of an institution and literally had nothing. Karen Ball was everything for her patients. Their payee, the person that taught them how to brush their hair, put on makeup, found them a room to live in, took them shopping for groceries, took them shopping for clothes, and also managed to organize their medications for them, see them every day, talk them through stressors. In community psychiatry, we talk about the importance of social networks and connections. We also teach our patients about the importance of setting healthy boundaries and that it's okay to set limits in relationships. That we can't necessarily pick our family, but we can pick our friends. And we have the opportunity for patients who have very little support to get engaged in some of our group therapies, which makes a huge difference for those folks. Finally, that sense of purpose is a sense of belonging or serving something bigger than ourselves. And again, I couldn't summarize it better than Kay Jamison, who says that purpose pulls us into the future, but psychotherapy pulls purpose from the past. And therapists like Daphne Noble in community psychiatry, who've been there for 34 years, know their patients so well that they can connect with them on what is meaningful to them, remind them of who the meaningful persons are in their lives, pick up the phone during a session and know whether she should be calling their neighbor or their sister or their daughter or their care provider. Those relationships that we develop over time help us to help our patients. So in terms of teaching these skills to patients, we talk a lot about CBT and DBT techniques to break the confines of negative core beliefs and cognitive distortions. At times, we use cognitive behavioral therapy or DBT. At times, we gently confront our patients. At times, we use persuasion with the goal of healing. We use a lot of motivational interviewing and help our patients to learn that we can look for progress, not perfection. More specifically, in community psychiatry, again, knowing our patients' life stories allows us to better engage them in care, to promote growth and healing. And this is the basis of the things we do that seem like checking boxes to lots of other folks. The individualized treatment plans that we develop are mandated by the Joint Commission, but they're meaningful for us, and we want them to be meaningful for our patients. We want our patients to be able to identify goals in their own words, be able to identify their own strengths, be able to define specific actions that they can take to work towards goals. We want to be able to monitor and measure their progress, and we want to be able to give them positive feedback when they're working towards those goals, or just be able to adapt and adjust them when they decide, that's not really what I want to do anymore. In IOP, we have our patients set a SMART goal every single day. So SMART goal being something that is specific, measurable, attainable, relevant, and time sensitive. So over the course of this IOP day, what do you want to do today? Great, we're going to check in with you on that at 1 o'clock today. And we try to model setting small goals, taking small bites, taking small steps forward. Again, progress, not perfection. And, as Karen Ball would say, quite a bit of grace and chocolate. Again, I couldn't say it better than Kay Jamison, who describes psychotherapy as effective if it relieves distress and improves the ability of patients to work, have meaningful relationships, and better master the inconstancies of life. For this to happen, patients must learn about themselves and then use that knowledge to become more self-reliant and gain insight that can be used in the future. We want our patients to become more self-reliant. We want them to graduate from ACT and move on to our outpatient mental health clinic. We even want our patients to graduate from the outpatient mental health clinic if they don't need us anymore and a primary care doctor could prescribe their medicine. And we always tell them that they're welcome to come back. Meaningful change, however, requires effort and discomfort. Right? Psychotherapy is not expected to be easy. So I learned about the parable of the butterfly from a community psychiatry patient who had a tattoo of butterflies and the words, "Flight is worth the fight." So I had her explain that to me. So this is a well-known but anonymous parable about the well-intentioned, compassionate soul who saw a butterfly struggling to come out of its cocoon and thought, oh, that beautiful creature, it shouldn't be so hard for them. Let me just snip open the cocoon, make it a little bit easier. And sure enough, it was easier. The butterfly slid right out with a swollen body and shriveled wings and never flew. Right? It's the actual struggle that Mother Nature knows is important for that butterfly to transform, to be able to build the strength in their wings and move the moisture to the areas that need to be in order for them to be able to emerge themselves and to fly. So struggle can serve as a catalyst for transformation. Overcoming obstacles helps our patients to build self-confidence, strength, growth, healing, and resilience. And it is the life stories that help us to partner with our patients to help them attain the goals that they want to in life. I wanted to point out that Anne is here today, who is going to be continuing this fantastic work on the importance of psychotherapy as the new director of the Jerome Frank program in psychotherapy here at Hopkins. I'm so thrilled to see what wonderful things she does. And I wanted to thank Kay Jamison for allowing me to use some of her beautiful words today with us. All of our community psychiatry patients who inspire me every day with their resilience, and our community psychiatry family of providers who lift each other up each day to continue to do the difficult work that we do. And thank you to all of you as well for listening. So.
Wow, that was very beautiful and very uplifting. Thank you, Dr. Meuchel. All kinds of fascinating things to talk about here. But let me ask you this. I guess that this work on resilience maybe seems most obviously of great value in the context of people who are not psychiatrically ill. And do you think it also has value in the setting of people who are psychiatrically ill, and are there ways of making headway in that context too?
That's a great question. So I think that the role of resilience is perhaps even more important in patients that have severe mental illness, because again, these are folks that constantly tell me, well, none of this is under my control, right? So we try to find each little thing that they do have the ability to control. And maybe it is reaching out to someone who's a positive support network for them. Through motivational interviewing, we encourage them to work towards smoking cessation, or to decide that they're ready to make that phone call to go into detox, right? So we teach our patients that they have power, and we want them to be comfortable with that, enable them to find that and to see their strengths, which is really where I think the resilience model makes sense.
Great. Thank you. Other folks have questions for Dr. Meuchel? Yeah, is that Dr. Burkhead?
That's a great question. So to summarize, tell me if I'm on track here. Dr. Burkhead asks about the dimensional perspective, and the patients that we see with severe mental illness in community psychiatry often have particular temperamental vulnerabilities like high neuroticism, which can make it very challenging to work with them in this resilience model when they can't see that. That is why we're fortunate to work with our patients for years. Generally, these are not things that we're going to accomplish in one visit or 1 week or 1 month. We are fortunate to develop relationships with our patients for years, sometimes decades, sometimes multiple generations of families. And we have to be able to be comfortable with something like motivational interviewing being a long-term process. Our training is often that you can do short-term interventions like 4 motivational interviewing sessions on smoking cessation and move patients forward. Well, yes, that is true. I had a patient that we routinely employed motivational interviewing for 5 years before I got her to agree to use insulin. And lo and behold, her A1C dropped dramatically. She lost weight, she felt better, her mental illness improved as well. And the hard part sometimes that is important for us to learn is that we want to give our patients all the credit. So Dr. Burkhead knows, he's working with me in IOP, that one of the first things I tell the residents is that one of the things that's most important for you to do is to give your patients credit, give them positive feedback. And when my patient came in and said, you know, I decided I probably could try that insulin, I said, that's fantastic. What a great idea. I can't believe you came up with that all on your own. And she ate it right up, big smile. She comes in now every year to tell me after she gets her mammogram, because that was the next thing we worked on, the annual mammogram. So she came in to tell me after she got her cataract surgery done, all of these things that were very anxiety-provoking for her, with grace and time and encouragement, and then giving our patients all of the credit. There's a little bit of wiggle room. We just have to be patient.
I think we should give you a little bit of credit too, but I agree with that general thrust. It makes a lot of sense. Dr. Redgrave.
Thanks, Jen. That was great. So we've been talking a lot about sort of chronic illness in our clinical research group, and I think just to sort of segue off of what you just said, sometimes when you work for, even if you as a clinician are not burned out, I think sometimes I sort of feel like, okay, I'm doing the same thing over and over again and expecting different results. And I'm wondering how you, as someone who cares for patients over a long period of time, decide, okay, we need to do something fundamentally different in the treatment, right? Or you just decide, no, look, maybe next time she'll do the insulin. Maybe so how do you? I'm just wondering if you reflected on that.
Well, Graham, that's a great question. So to summarize again, the question is in patients with chronic illnesses, how do you decide how long to keep doing the same thing over and over without any different result versus say we just have to go sideways and try this a different way? So one of the benefits in community psychiatry is that we have that team, we have the therapist, and we have the psychiatrist. So I'm not the only one doing that motivational interviewing. It's reinforced by the therapist much more frequently than me usually for a lot of our patients, and I find that very helpful. And again, that team approach, we bounce ideas off of each other. And the open door policy that we have in community psychiatry, if you don't have a patient in your office, generally your door is open. And one of the things that I love the most is that I can just go right down the hall and sit in Anne's office or talk to Dr. Cullen and say, what am I doing with this patient? It helps to talk those things out. And then we look for, we set limits as well when there is a point of no return. When someone's being hospitalized for diabetic ketoacidosis, we've got to do things a different way. We have patients that want to live independently, but they can't stay out of the hospital. Sometimes we have to be directive with our patients. That's always a fine line, but to say, you know, I think this is really important that we involve more people here to support you. And maybe it's because of the relationships that we have with patients that sometimes they're able to hear that.
Dr. Rubel.
Well, Dr. Rubel is asking whether, in my opinion, it takes an hour-long sit-down session with a patient to do effective psychotherapy. And thankfully, I don't think that it does. We are blessed with what seems like a tremendous amount of time with our patients, but we still have to work on a schedule. So in community psychiatry, we have a half hour with our patients, which often doesn't feel like enough, but it's quite a lot. And we can accomplish quite a lot in that half hour. If our patients walk in late and they've overcome obstacles to get to clinic, they arrive 15 minutes late, we don't send them home. We say, come on in, I'm so glad you made it. It must have been a difficult day. Come sit down. We've got 15 minutes left. Let's see what we can do.
On that note, we will wrap up. That was wonderful. Really lovely grand rounds. Thank you so much.